Good morning, everyone. I want to give a very warm welcome this morning to Dr. Evis Sala, our speaker for the Frontiers in Oncology seminar series today. Dr. Sala actually has background, was born and grew up in Albania and received her medical training there. She also did a residency in surgery before moving to the University of Cambridge in the UK for further education. She finished both a PhD in statistics and epidemiology in Cambridge, as well as clinical training in radiology. Her career has taken her all over the world. She previously served as chief of the body imaging service at Memorial Sloan Kettering Cancer Center and a professor of radiology at the Cornell Medical College in New York City. In 2017, she moved back to Cambridge, where she is now a professor of oncological imaging. She also leads many of the important initiatives run by the Cancer Research UK, including the UK Cambridge Centre for Advanced Cancer Imaging, as well as the Integrated Cancer Medicine Program. We're very lucky to have Dr. Sala here today because she is really a leader in an emerging and new field of radiomics and radiogenomics. She has developed robust methods to integrate quantitative imaging data with genomics, proteomics, and metabolomics, all with the goal of improving diagnosis, improving prognosis, and improving our ability to prognosticate treatment outcomes in patients with cancer. She's also played an important role in developing artificial intelligence methods for image reconstruction, segmentation, and data integration. In addition to all of her scientific accomplishments, Dr. Sala has been widely recognized and is sought after for being an outstanding educator, mentor, and speaker. So please join me in warmly welcoming Dr. Sala. I want to remind everyone, just as an administrative point, to please enter your questions during the seminar into the Q&A box of Zoom so that we can retrieve them in the end for Dr. Sala to end the seminar. So with that, I'll turn it over to Dr. Sala.
Thank you very much indeed for such a warm welcoming, and it is really wonderful to be back, albeit virtual, but hopefully at some point we will be able to see each other in person. We so much are longing for that. So just a couple of disclosures from my side. So why high-grade serous ovarian cancer? It's a few concepts I wanted to highlight, which will actually make sense then through my talk, the work we're doing in ovarian cancer. It's a very interesting disease because it has an early spread through the abdomen at the point of presentation. So unlike some of the other tumors, when usually they're localized, for example, like breast cancer in the breast or other tumors like kidney or renal cell carcinoma in the kidney, ovarian cancer at presentation presents with multiple metastases throughout the abdominal cavity. There are no actionable oncologic mutation. Almost all cases exhibit a TP53 mutation. It does have a very chaotic genome, and it's driven by copy number alteration, so it's very complex. And also over time, there are profound changes, and this clonal evolution of disease actually drives resistance. So it is a very, very interesting disease, but then also obviously comes with the challenges of studying the disease, which is so heterogeneous. So what are the challenges in ovarian cancer imaging? And I'm not going to concentrate on the early detection or lesion characterization because this is not the focus of the talk or even the interest I have, but mainly on how do we really make use of this quantitative information we collect, but we actually throw it away, in addition to the important qualitative information that we use in everyday clinical practice. So, and in addition to the segmentation work that I'm going to describe to you, I'm also, which is crucial for volumetric tumor assessment, I'm also going to share with you our work in radiomics and habitat imaging, again, very, very important. Also the work we're doing into mapping the tumor heterogeneity in ovarian cancer, and this is not just in space, but also in time. So dynamic monitoring both in space and in time for tumor heterogeneity. And ultimately, I think what is important is the integration of all this data to actually predict the early treatment response or resistance, as a matter of fact, and ultimately the outcome. So let me just start with the sort of clinical problem. So as I sit on my routine clinical days, and you sit in front of your PACS monitors, and you look at the CTs of patients that have come back after they've received neoadjuvant chemotherapy. So this is chemotherapy prior to delayed primary surgery or interval debulking surgery, the old terminology. So the patients come back, and these are 3 patients with representative images. This will be the pelvic disease for simplicity, and the treatment is given, and then the second CT is done, and then it's really easy for us as radiologists to actually qualify the progressive disease because all lesions have increased, so it's not a problem. Also, very rarely it happens, but you do have complete response and partial response. That's not a problem. What becomes really difficult is the stable disease, because the stable disease, some of the lesions have grown, some would have shrunk, and overall there is not much change in the volume of tumor. So it's like a basket when we actually throw all these patients that we don't know where to classify them. Now, unfortunately, in ovarian cancer, this is about 30% of these patients, which means that in these 30% of the patients, we're not actually classifying them correctly, which means that we are not making them, we're not really trying to come up with new treatments for them or enrolling them in new clinical trials, because we still classify them as stable disease. What we want to do in the future, and what we're working towards, is we really want to be able to take into account the information on tumor heterogeneity, from the circulating tumor DNA, from the tumor microenvironment, are those hot or cold, and combine it with the imaging, so we can then confidently say, well, these tumors are really, immune cold, so this patient is developing resistance to chemotherapy, so they should either undergo earlier surgery because the tumor is not chemo resistant, or they should be enrolled in a new clinical trial with a novel drug. So we do have this heterogeneous disease, which really exhibits extraordinary heterogeneity. Why? Because we have this heterogeneity between patients. We have it within a patient tumor, so between the sites of the tumor, but you also have this within the same lesion. So it's 3 levels of heterogeneity: within lesion, in between lesions, and in between patients. So clearly there is a challenge, because heterogeneity within a single lesion does not actually represent or capture the overall disease heterogeneity. And we know from molecular studies that this heterogeneity precisely that drives the treatment resistance and then metastatic disease. But wherever there is a challenge, there is an opportunity, which means that we have got together with a computational, with a computer scientist, to actually develop new methods to capture this special heterogeneity, and as well as temporal one, in a better way, and to try to unravel the tumor microenvironment. And just how we do this, well, one of the ways to do is to use texture analysis, so looking at the texture of the lesion, not just the size of the lesion. And this is just one of the, or 2 of the texture parameters, but just for simplicity, those are paintings from Metropolitan Museum of Art and SUC, and even with your eye, you can say, well, this painting on the left is very heterogeneous, and as you go towards the right of the screen, it's very homogeneous, this Mark Roscoe painting here. So what you do with texture analysis, rather than just qualifying it, you can actually quantify it. You can say, well, this lesion is very, it's homogeneous, and then it goes very heterogeneous, and the other way around with the entropy. So now you have quantified what you saw, and you can use those parameters to integrate it with the other data. So just of a sudden, your images became also quantitative, not just quantitative. So we've moved from the simplistic ways, from just the simplistic metrics of heterogeneity, to actually designing ways to capture the inter-tumor, but also the intra and inter-tumor heterogeneity. So schematically, basically, not only we want to capture and quantify how different those lesions are within a patient, but also how different the different regions within the lesion are between each other. So both levels of heterogeneity. And we've done this using our machine learning methods. And this is just an example of 2 patients, just to show you two patients with high-grade serous ovarian cancer. And as you can see here, the patient on the top survives about 20 months. The disease is less heterogeneous than the patient on the bottom, which has a lower volume of disease, but much more heterogeneous disease, and it barely survives the 8 months. So we went and looked at our metrics of heterogeneity into and so how they relate to the Clover subtypes in ovarian cancer. These are genomic subtypes. The mesenchymal one, very well known for having a very high resistance to platinum-based chemotherapy, with as much as 70% of patients developing first-line resistance if they belong to the mesenchymal subtype. Interestingly, within this mesenchymal subtype, we found patients that actually survive very well, such as the patient on the top here, because they have homogeneous disease, or one of the reasons, despite having a higher volume of disease compared to the patient at the bottom here, which doesn't actually survive the year, which has very little disease, but is very heterogeneous. So you can see how now imaging can actually help even subclassifying within the same sort of genomic subtype. And we did some similar work here in the setting of immunotherapy. So these are patients with high-grade serous ovarian cancer enrolled on 3 immunotherapy trials for recurrent disease at Memorial Sloan Kettering Cancer Center. And here, as you can see, if the patients had more sites of disease and the large lesion was more heterogeneous, they had less clinical durable benefit compared to patients with less sites of disease and with the disease which was more homogeneous. So this is mounting evidence that the disease heterogeneity really plays a role in ovarian cancer. And it is important because you can't really biopsy every site of disease, because there are a lot of sites of disease in ovarian cancer. You can't really use biopsies to actually represent the spectrum of disease. So what we did as a further step, using TCIA as the validation set, we looked at, we used machine learning to integrate to create our vector, our metric. And the IRCG here includes the intra and inter lesion heterogeneity. Our texture metric was called CLUDIS, which actually tells you in simple words how dissimilar the dissimilar areas are between the lesions. So the extreme heterogeneity for simplicity. The conventional clinical parameters include the CA125 and age, as well as the genomic classifier. As you can see, they both really are very good at predicting progression-free survival in the TCIA data set, so they're validated TCIA data set. And what is really interesting is that the vector or the metric that combines this intra and intra-lesion heterogeneity does much better in predicting platinum resistance compared to just conventional vector, or the ones that averages this heterogeneity. And out there in literature, there are a lot of studies who actually use this average heterogeneity of the lesion, which actually defeats the purpose of really using radiomics to precisely evaluate the heterogeneity. So, so far, this is retrospective work, or the work done on the retrospective data sets. So one might argue and say, well, you know, how about longitudinal, and how about sort of having some tissue correlation? So this is an N equal 1 of a patient, but it has many, many data points. And this is a patient who underwent multiple lines of chemotherapy, including chemo vacations or chemo breaks, for high-grade serous ovarian cancer over a period of 9 years. And we had tissue samples from various lesions in this patient. We had samples from the primary tumor at time of surgery, but also along the lines of various treatment, also various lesions developed. And as you can see here, there are lesions that grew, for example, in the vaginal calf and around the spleen, and there are lesions that shrank. So this is just volumetric sort of longitudinal trace of the volumetric change of the lesion. Now, all those lesions had biopsies, so we can actually look at them in terms of tumor microenvironment. And what we found was that the primary lesion, as well as the lesion of the vaginal calf and the spleen, so the growing lesion, were immune excluded because there is an increase in the Wnt signaling pathway. While the other lesions around the liver and in the right upper quadrant, they're actually immune hot. So this is just a link between a tumor volume and the tumor microenvironment. Was this useful? Yes, because we don't know much about the interaction between the cancer, in this case ovarian cancer, and the host immune response. I think it highlights the point that analysis in both time and space is very important, especially in the setting of metastatic disease, and that metastatic tumors exhibit this intra-patient heterogeneous tumor growth that is really important, especially in the setting of multiple lines of chemotherapy. So we took another step. We looked at So initially we looked at growing and shrinking lesion, then we looked at the texture of the lesions, of all these lesions. So what we found, which was very interesting, is that the late metastases, not the growing or the shrinking, but the late ones in time, such as the liver and the vaginal cuff. So the liver here is the blue one and the vaginal cuff is the red one. They show much more heterogeneity over time, or change of heterogeneity over time compared to the early metastasis. And we rightly so asked the question, is there any matching genomic heterogeneity? And indeed there was. This is the phylogenetic tree. And as you can see, the trunk of the tree, and then you can see all the branches of the tree with the various deposits. And as you can see here, the liver and the vaginal cuff, which were the late metastases, also the branches here are longer, there is a higher mutation rate, so they are much more heterogeneous. So now we're linking this heterogeneity on imaging, which is matched by site, with really more heterogeneity in terms of genomic heterogeneity. So I think the conclusion from this part is that in order to induce a successful immune response in the patient, we must induce a response in all metastatic lesions. So we must find a better way to actually look at treatment response in a multi-site disease than we currently do. And obviously the new treatment strategies, they have to take into account this heterogeneity rather than the overall patient response. And of course, we are now aware that not just for ovarian cancer, but other tumor types, that this is really microenvironment dependent. So since I've come back to Cambridge in the last 2 years, I've set up, as a group, we've set up our radiomics workflow. And this goes back to actually acquiring raw data on CT. So we've taken a step sort of back or forward, depends how we see it. So we start with the raw data rather than with the reconstructed images. And then we've got a reconstruction step here, and then all the data from our center, along with the data from collaborating centers such as the ICON-8, which is a large multi-center study, they are pulled into our XMelt repository, which is hosted in our university computing cloud computing. Then we do automatic segmentation of the whole tumor burden, and I'm going to show you the results on that. Along with the sub-segmentation, again, I'm going to show you the results on that. And then radiomic features are extracted and everything is put into the prediction model in order to actually, including the clinical data, the pathology data, and the genomic and ctDNA data were available in order to actually create, to integrate the data and really predict the treatment response and the outcome. And I'm going to also show you the efforts we've done to actually really colocalize the images where the biopsies are taken in a way to maximize that correlation between the imaging and the histology or the genomics. So starting with the segmentation, this is really amazing work of one of our PhD students and Thomas and Leonardo, which is my postdoc. Looking at, and this is the data on 100 patients with ovarian cancer, and look at the results of the automatic segmentation. So red is the observer 1, and green is the observer 2. So one of them is me, and the other one is another equally experienced radiologist. And the automated method is basically the automated segmentation. This is based on deep learning, and as you can see here, you can't really tell between the very experienced radiologist and the automated segmentation. And these results are very encouraging. I think they're excellent for momentum. Our results in the pelvis are even better because momentum is inherently more difficult to auto-segment. So this is now fed in our radiomics pipeline. We can now do the automatic segmentation. So we've now linked the automatic reconstruction to the segmentation step. So what I refer to automatic sub-segmentation is that inherently the tumors are heterogeneous, and that heterogeneity is in 2 levels, at least phenotypically. It is on the macroscopic level, so we can see it, and as radiologists, we prefer to qualify it. So we say, oh, the lesion is very heterogeneous. What we mean is that there are cystic parts, maybe calcified parts, like in this case here, and there are more solid parts. So, so the first task is actually to quantify this. For some that you already see, how do you actually quantify it? And you can see here again, this was using a novel framework for tissue-specific solid tumor subsegmentation. Was all based on unsupervised fuzzy clustering. And this is the omental disease and the pelvic disease here, and automated versus gold standard, and gold standard being a radiologist. And you can see it's all based on the whole stimuli. So it's very explainable and interpretable. Just to show you again the same images, we've used the two-stage, the manual versus automatic segmentation. This holds very well for ovarian cancer, very well for mental metastasis, but also we've done that for kidney tumors as well. This uses an iterative process. As you can see here, our model does much better. This is the overlap between the ground truth and the automatic subsegmentation, and this performs very, very well compared to the other benchmark models. So we've done the segmentation, subsegmentation, we've extracted those texture features, and ultimately all this is very useful because you really want to integrate into your model. So what we've done, we've curated a very rich data set, and you can see here as an example of the richness of the data we're integrating from the CA125 level, the patient's age, various types of treatment, very important, and the intervals between treatment, as chemo sessions, all the radiomic features, as well as some qualitative features such as the ascites, pleural effusion, number of disease site, and also the ctDNA. So we had ctDNA on all these patients. So this is our framework. So we use a machine learning framework, and we've split this in training set, a hold-down validation set, and an external validation set that comes from the St. Bartholomew Center in London. And what we find, and this is just the preliminary data, is by integrating more data sources, our error goes down, so the model becomes more robust. So more data integration, the better it is. And in terms of radiomics, not only we concentrate on the overall radiomics, but also we look at the core versus the outer region, the center, and also the interface between the tumor and the rest of the microenvironment, the adjacent tissues. So far, we haven't biologically validated our radiomic methods, and I think it's very important if we're going to use those moving forward as the biomarkers. We need to know what they mean. So what we do, in addition to using those in our models for integration, we create tumor habitats. And those on CT are based on orthogonal texture maps using unsupervised clustering. And we use them to obviously predict the clinical endpoints of interest, but also to sample them because we want to know what they mean. And this is really early work that just started, but I'll give you a few insight into what's going on. So the texture maps are actually created, and then we use the principal components and the spatial clustering to actually create those habitats. They've got two steps here. We use the Gaussian mixture modeling, but then we also use the hidden Markov random field to actually ensure that there is spatial cohesiveness in our habitats. So now in each tumor or lesion, we have these habitats with these color maps that we can actually use to target our biopsies. And indeed, that's what we did. We teamed up with Canon Medical System to actually use their already available machine that can fuse ultrasound with CT or MRI. But now what we've done, we've actually made it possible. So on top of the just fusion of CT with ultrasound, we can actually fuse those habitats. And we've done 12 patients so far. It's been a bit of a roller coaster with COVID on the way, but nevertheless, we've managed to restart our program again. And really, this is now integrated in our clinical workflow. So we're actually using a machine in the clinical setting as the patient comes for their biopsy prior to neoadjuvant chemotherapy. And this is only adding 10 minutes to their usual routine biopsy procedure. So of course, there is a little bit more preparatory work. So the CT is obviously acquired and segmented before the patient will come for the ultrasound biopsy. And this is happens in radiology's part, the computational pipeline, as well as put in motion to actually subsegment the lesions, to the texture extraction, the habitat clustering, and everything is exported to the ultrasound machine. So the patient arrives in the morning of the biopsy, the CT with the habitat is actually in the machine ready to be used, to be fused with the ultrasound. And of course, the clinical samples are taken, but also research samples. So again, just this pipeline, but in a more colorful way for us, the imagers. You can see the CT with a large tumor outlined. This is our texture map with 3 habitats. It obviously will be challenging to actually target the blue one, but we've targeted successfully with both the green and the red in this case. And this is just to to show you the procedure itself. You can see the track of the needle here, going through the lesion, going through the green habitat first, and then it goes through the red habitat. So this is prior to neoadjuvant chemotherapy when we need a biopsy. But then how about patients who actually go for primary surgery, when we actually have the opportunity to have the whole tumor out? So actually we can really do a much better matching of the histopathology and genomics compared to just sampling with a needle biopsy. And in some of the window opportunity trials we're doing, we need both methods because they receive chemotherapy and then the whole tumor comes out. So we need two methods at sampling initially and also at surgery. So we've done some elegant work in that a while back now in ovarian cancer when we looked at precision tissue sampling using 3D molds. So the way it works, we acquired images called PET and MRI on those patients. In terms of MRI, we had both perfusion and diffusion. So the F and the D are from the IVIM, diffusion-weighted images, or intravoxel in current motion, which looks at the inherent perfusion using the diffusion. And this is the K-trans, this is the permeability, so the liquidness of the vessels rather than true perfusion. And of course, the PET, the SUV map from the PET. We use those are all co-registers, obviously, and then we use the K-mean clustering to actually derive those tumor habitats, which each of them have a unique combination of perfusion, diffusion, metabolism. So this is one of the patients here, or the MR of the patient, with the habitats fused. And as you can see here, there are 3 habitats in this ovarian mass here, the green, the blue, and the yellow. This is just loculated fluid on the other side. And then there is a metastatic deposit in the omentum to the left side anteriorly here. And this is blue, which means that is the same phenotype on imaging as the blue part of the ovary. So then the molds are printed. The mold is designed, so the lesion is outlined on the MRI, and then the mold is designed and printed accordingly. So it is not only patient-specific, but it's also lesion-specific. And this is the arm of the patient here. This is my hands there to collecting the mold. Each slice on this mold corresponds to a slice on the MRI, to an image on the MRI, and the slice thickness is the same as the thickness on the MRI. And then you have obviously real coordinates of where those lesions are or those areas are in terms of habitats. So half the sample goes for histopathology and half the sample goes for genomic analysis. And this is phylogeneity, which I call it radiophylogeneity, because actually the sampling is done based on imaging. And again, the trunk, as expected, will have a TP53 mutation. But as you can see here, very interestingly, you have 2 main branches of the tree. And the ovary yellow and green habitats here at the back, they branch together. So phylogenetically, they are very similar. And the ovary blue, the omentum blue also branch together. And some mutations which were subclonal in the ovarian blue habitat, they became clonal in the omentum blue, showing that probably the omentum disease is slightly more aggressive and showing that evolutionarily they are actually similar. So we now, I can't say that we've got definite proof, but at least we have some insights that actually what we see with imaging might potentially reflect what is happening in the underlying sort of tissue. Although I'm very aware we are a lot of scales sort of separate because that's just a tiny sample and the genomics of that. So we've done a few more cases of that, and this is just to show you how heterogeneous the disease is, not within the patient, not only within a patient, but also in between patients. You can see the ovarian mass in another patient here, the omentum, and the pouch of ductless disease. And those are various molds printed on the team here, harvesting them from OR. So this is quite an operation. And we've done histology and the multiplex IHC. And again, looking at those samples on a recently published work, we again, as we sampled via imaging, we also can see those hot and cold habitats with their underlying, different signaling. So they're obviously on the cold one, the MYC and the Wnt signaling pathway is increased, and you can see the NK cells and the cytotoxic cells are actually increased on the hot habitats. But also we can see now there is some correlation between some of the imaging features as denoted here. For example, the F, which is the indirect perfusion, was correlated with the Wnt signaling pathway, and the permeability or the liquidness of the vessels was inversely correlated with the TILs. And as expected, the SUV was correlated with the glycolysis. So this is small number of patients, only 10 patients, but there is something for us to actually extend and understand better. So, so far, I think what I've showed you is that we've worked on multiple levels, not just in terms of the computation, but also in terms of tools to actually sample tissue in a much better way for biological validation. But also, I would hope that in the future, we can minimize the number of biopsies and biopsy a more meaningful lesion, and maybe really do away with biopsies in some maybe more distant future. Maybe it's a dream, but it's good to have a dream because then you follow the dream and maybe it becomes reality. So I've shared with you work on tumor segmentation, on habitat definition, that on CT is based on texture differences, but on MRI is based on differences in multiparametric profiles, depending on what sequences you use. And of course, I shared with you the work on fusion biopsies as well as the 3D tumor molds at surgery, and also the work on data integration. So in a way, we now have this data universe. We've got the radiomics, we've got the treatment details on every patient, we've got the blood-based biomarkers, the ctDNA, we've got the histopathology, and also we've got the molecular profiling. So the radiogenomics really sits in the center of that. But what is more important now, we enter this era of not just correlating and comparing, but actually integrating. Because I think this is really key. How do we actually integrate all that information? So now I would expect the audience at this point to say, okay, this is great, and it's beautiful, but what does it actually do for the patient? So I don't know about Stanford, but this is what happens in the other places I've worked. You sit on the MDT, and you have multiple members, and then it becomes a bit of a cacophony. Everybody says something and you aggregate the information, but there is no real integration, okay? So there are many streams of information, but they're not really integrated. And it's no surprise they aren't. This is a typical patient we discuss, for example, in an ovarian cancer treatment planning conference or GYN oncology MDT. And it is difficult to integrate all that. And can you imagine more, biopsies? This is just the types of treatment the patient had in the CTs. But actually, there's much more information that I can't fit in these slides. And no wonder we can't really do that in an efficient way. So let me just give you an example. As I was preparing one of the cases that was enrolled in a trial, I was looking at the CT time point 1. And this was one of the marker lesions in the lesser sac here, difficult disease to resect. Obviously, the patient had gone to a neoadjuvant chemotherapy. With the bare eye, you can see actually there is some heterogeneity. Like we said, we used our auto-segmentation method, and this is a volumetric assessment here of this lesion. The patient comes back after treatment, and the resident did the first report, and he said this is progressive disease. The disease here up in the left upper quadrant hadn't changed that much, but this mass here in the lesser sac has actually increased in volume. Interestingly, we ran out our auto-segmentation and subtissue segmentation pipeline, and yes, the volume is increased, obviously, but what is this is accounted by an increase in the cystic part of the tumor. So the tumor is now necrotic with very little solid elements. So actually, the patient has probably responded to treatment, yes, the subsequent CA125 showed actually that the CA125 went down, but it was a lag in time. So what I want to be able to do when I go to my MDT in a year or two, maybe not that distant, is actually to be faced with something different, to actually be able to look at the volumetric change of the tumor. This is another case with various components. I know what the stage of the patient is. I know if there is a wild type of BRCA or not, what the CA125 is doing, and this is the baseline integration of data. And then maybe target the biopsy in a specific way, in a more, directed by the habitats, by heterogeneity rather than just in a blinded way. Blinded in terms of course, not blinding for accuracy in terms of safety, but in terms of the heterogeneity of the tumor. And then dynamically track it. Dynamically track not only the CA125 level, but also see what happens to the tumor. And visually, immediately you can see that the tumor volume might be slightly bigger. In the second case, it's not that uncommon actually, but there is more cystic components that actually the patient is responding. If you were to just do RISs, this patient would be in progressive disease. And of course, ultimately, you want to overall integrate the data. You want to build in warning signs that, yes, the disease might be increasing in size, but actually, the cystic component is increasing. There is the ctDNA is going down, so the tumor is responding. And so you get alerted as you do the work that this is actually partial response. And it will be really even another layer of complexity maybe, but very, very needed, that you really see where your patient is in the last 100 patients treated or with the same characteristics. And then you can really find another patient which is similar and compare the treatment and see how you can learn all the time from one patient to another. So then the tumor board or the consultation, as a matter of fact, becomes more of an integrated one rather than just comparing and correlating one. So I think, I've given you a glimpse of the work we've done. We've been busy publishing some of this work in various journals, but I think the highlight of my work is really people I work with. And without these wonderful members of my group, only half of them, because this is in the window between the two lockdowns, we managed to have a barbecue. So this was a success in the summer. Unfortunately, now we're all spread around because of the lockdown. And again, thank you to a lot of collaborators over the years. I've been very fortunate to work in many wonderful centers and been mentored by many wonderful mentors, which I'm very grateful for. And also my colleagues in the integrative cancer medicine, because it's just amazing how much one learns with the cross-disciplinary interaction with other disciplines. And thank you very much for your attention, indeed. Happy to take questions.
So thank you very much, Evis, for that fascinating and insightful seminar. It really highlights the promise of integration between imaging data that all of us have looked at sort of on a more kind of ad hoc way on imaging studies and integrating that with genomic and other biochemical markers. I just want to remind the audience, if you do have questions, please put them into the Q&A box of Zoom and I'll read them out. Maybe I can start with a couple of questions. This area was new to me. One of the questions I had was, when you develop your automated segmentation and analysis platform, do you have to do that differently for different imaging modalities like CT or MRI or ultrasound? I mean, are you picking up differences just in the density, or is it based on contrast? I'm trying to get a more kind of granular sense of what the parameters are.
So that's a great question. So far, the work I've shown you on automatic segmentation, subsegmentation is purely CT. And there is a good reason for that. Is because CT is used routinely for treatment monitoring and staging in ovarian cancer patients. And in oncology, it's really safe of neuro and musculoskeletal. CT is really the main workhorse. So we really want to develop something that we can use in clinic soon, rather than later, and it will be used in not just in the center of excellence, but really out there in every center that has a CT. It is based on Hounsfield unit, as I showed. So the automatic subsegmentation, it's really a threshold with fat, fluid, calcium, and this is why also it's quite interpretable. So it's a whole discussion now on AI interpretability and acceptance and all that, but it's some nice work we're doing actually with getting the patients itself involved into really understanding more how we develop the AI in the context of segmentation.
Thank you. The other question I had, you mentioned that you had done work, in the same patient looking at imaging data and circulating tumor DNA, which is, emerging or has already been established as really a great way to look at treatment response. Do you see the imaging data? How do you see it adding to a circulating tumor DNA measurement? Do you find evidence that they provide orthogonal pieces of information?
So it's interesting. I mean, it depends on the cancer, and it's interesting. You said, how does the imaging add any value to ctDNA? I would turn it around. Does the ctDNA add any value to imaging? Especially on the multi-site disease. So in ovarian cancer, in our data, adding ctDNA improved the model, but adding radiomics improved it even more. Now, if you added the radiomics and then you added ctDNA, actually the model became slightly better, but not significantly better. because it's a multi-site disease and it's very heterogeneous. So I don't think ctDNA is actually telling us about the heterogeneity of disease. It's the same as some of the renal tumors. You expect actually ctDNA to be quite sensitive. We are having trouble of actually having enough, sensitive enough method to actually detect the ctDNA in a cancer. To think you're going to detect a lot of it. So I think I see them as complementary, and I think they are tumor specific.
Mm-hmm. Thank you. We have a question from Daniel Kapp, and the question, and Daniel Kapp says, excellent work. One of the most significant predictors of outcome, however, is tumor debulking to minimal residual disease. Can you predict this better with your integrated studies prior to initial surgery or after neoadjuvant treatment?
Yes, and I didn't actually show the data, but in the very first paper we did with intersite, not inter-intersite heterogeneity, the patient with less heterogeneous disease had a better debulking, so optimal debulking. So yes, and then we've moved to neoadjuvant setting. I guess the other thing that where the research is focused more now in neoadjuvant setting, in Europe, we use neoadjuvant chemotherapy much more than primary surgery that is in the US. I just think it's also a change of scenery.
I had one last question. If there are other questions from the audience, one of the really interesting things I found in your presentation is the attempt to correlate specific genetic changes in a particular area of a tumor with the imaging characteristics, whether it's Hounsfield units or things like that. Do you think that's going to be tumor specific, or they're going to be sort of uniform principles that you can take across tumors? For example, increased textures associated with mutations in this pathway. I know you mentioned a couple of pathways like Wnt signaling or some of the other things.
So I don't have data enough to actually say to you to answer the question, is it going to be tumor specific or not? I don't know if it's going to be lesion specific either. We're working on getting multiple sites now to, in the same patient. But I would like that we had some, you're right, if you have some parameters that are actually associated with certain genetic alteration, because if that is the case, and I can't answer the question now because we don't have the data, it'll be great actually, because at least you can use the imaging like a surrogate biopsy in a way, and then you can say, okay, I want to biopsy this area, which is associated with that genomic alteration, or even not forego the biopsy, the intermediate biopsy, and then biopsy next time when the next cycle. So, that modify our pathway in a way. But I think we're still a little away from that.
See, great. Any other questions? If not, please join me in thanking Evis Sala for a fantastic seminar. Thank you for visiting us at Stanford, and hope to see you in person in the near future.
Thank you very much. I'm very sorry for the screen swapping. It did work on the pre-talk, but
it was fine. It worked perfectly. Your slides displayed fine. So thank you again, and have a good day, everyone.
Thank you. Likewise. Thank you.
Bye-bye.